Good evening, everybody. A warm welcome to all. It is very good to see you all in this pleasant evening for this interesting webinar. I am Bhuvaneshwari, the moderator of the session. We, Forts, as an organization, take immense pleasure in inviting you all to this session as we always serve with the tagline, Innovating for Good Health. Forts always believe that everyone deserves a radiant skin. Our skin is the best accessory we need, and we need to take good care of it. Here we have a wonderful speaker who is going to share valuable information as she has a rich knowledge on enrichment of skin. On behalf of Forts, I welcome the speaker of the session, Dr.Sharmatha Kumar, who is going to talk about management of acne scars, tips and techniques. Dr. Sharmatha Kumar has completed MBBS DDVL and she has done her fellowship in aesthetics and lasers FAM. She is a consultant dermatologist at SIMS Hospital, Vadapalani, Chennai. She is the managing director and aesthetic dermatologist of Inventive Face and Skin Clinic. She has a keen interest in aesthetic dermatology and cosmetology. She is currently a member of the research and development panel of mosaicwellness.com. Dr. Sharmatha does regular TV shows of skincare and she has conducted more than 20 camps. As a matter of fact, her personal interest is in yoga as she not only adds tone to the skin but also to your body and soul. Till yesterday, we were getting around 300 registrants, not only from India but across globe. This evidently shows the importance of the topic as well as the speaker. So once again, on behalf of Forts and behalf of the registrants also, I'm inviting you, ma'am, and we are eagerly waiting for the talk. And if any of the registrants, if you have any questions during the presentation, please text by clicking the question tab under the screen. Doctor will be answering all of your questions at the end of the webinar. The virtual podium is on to you, ma'am.
Thank you. Thank you so much for the kind introduction. I'm more than happy to be here to actually be talking about acne scar management because it is one of the topics that is a very complicated topic to address because we know that we do not have almost complete cure or complete treatment for any sort of scar on the skin. So let's start off with this good topic. Can you start enabling screen sharing so I can share my presentation to the audience?
Yeah, sure, ma'am. I did the screen sharing option. You can start this. Yeah.
So like I had said, today's topic is going to be management of acne scars. We will be discussing the tips and techniques, and let us go into this in detail. So before understanding acne scars, we have to understand why this should be addressed. So acne itself is the primary condition that is responsible for this acne scarring. And acne affects almost 80% of adolescents, which is predominantly men, little boys, and 40% of adults over the age of 25. In this category, predominantly they are women. We all know that one of the intrinsic factors for the development of acne is genetics, and it has a huge psychological impact on the patient's life. The quality of life is comparable to those suffering from chronic diseases like asthma, seizures, and diabetes in many of these studies. So it is very important to address acne, following which we will start addressing acne scars. There are a lot of extrinsic factors which also has to be addressed before the patients develop acne scarring. We all know that when there is a lot of friction and manipulation, the acne actually manifests as marks and scarring more easily than in skin that is maintained cleanly. Patients who use occlusive products or cosmetics facilitate new lesions to develop because they block the pilosebaceous units. And of course, we all know that steroids, anti-epileptics, and most of the oral contraceptive pills are responsible for developing acne. And these variant of acne are called acneiform eruptions or drug-induced variant of acneiform eruption. Other than that, we have a lot of other external factors like diet, stress, which are responsible for acne. So Western diet may be associated with acne, because it has a lot of skimmed milk, dairy products, and sugars, which are responsible for a high glycemic index and result in insulin resistance. There was a study that was actually done, and it showed there was a low prevalence of acne in countries like Papua New Guinea and Paraguay because the diet was predominantly of a low glycemic index. This is the reason there is an increase in adult onset of acne. And stress was also found to be more amongst university students who associated themselves with exam stress. So acne again is caused by stress also. So we now know the causes of acne. Let us understand the way acne develops itself. So we know there are four pathophysiology of acne. First, there is plugging of the hair follicle or the pilosebaceous unit on the skin. And when there is such plugging, there is also a existing hyperactivity of the sebaceous glands, which is responsible for the accumulation of the sebum on the skin. And a proliferation of certain bacteria, which are known as Propionibacterium acne, in this sebum is responsible for an inflammatory reaction on the skin that manifests as acne. So this is picturesque depiction of how acne develops, the different stages or grades of acne. So first, there is an occlusion of the pilosebaceous unit at the surface of the skin. It could be anything that is responsible for the occlusion. So most of the sebum that is actually being produced gets accumulated to form a comedone. Now this could develop in the skin, or it could also be exposed to the atmosphere, which is known as a closed comedone or an open comedone, commonly known as the blackhead or the whitehead. So when this gets infected with the Propionibacterium acne species, it results in inflammation and the skin erupts into a acne or into a pimple. So this is a clinical picture depicting multiple types one of the erythematous papule, as you can see on this patient. So let us look into more such lesions. Acne can also be papular acne or papulovesicular acne. So papules, we all know, is just an elevation on the surface of skin. So it can become secondarily infected, or it can cause a vesiculation. That is where there is an accumulation of clear fluid in the lesion. And here I point at papulonodular type of acne, where there is a little bit more inflammation into the deeper layers of the dermis or superficial layers of the dermis. And this kind of inflammatory infiltrate is responsible for a firm variant of acne. And if you take a look at this patient, it looks predominantly monomorphic, which probably is due to some sort of drug-induced acne. So the etiology will be discussed in detail. And such nodules, when they get secondarily infected, there is a tendency for them to develop cysts or accumulation of pus within these nodules. These are known as nodulocystic acne. The patient has multiple papulonodules. However, this nodule has developed a secondary infection and is responsible for this cystic collection, which can cause very bad scarring. So we can discuss that when we come into the actual topic of scars and scar treatment. There are a couple of other variants of very severe acne. Acne fulminans is something that is so severe that it is associated with a lot of systemic infections. It's common in male, and it can manifest with a lot of systemic infection, resulting in post-streptococcal arthritis, or manifests along with fever and has secondary streptococcal infection on the skin as well. Acne conglobate, on the other hand, is a variant of acne that has all the previously discussed topics. It can have comedones, it can have papules, pustules, papulonodular lesions, even cysts which are so infected, and they can even form sinus tracts. These sinus tract forming acne lesions are very, very difficult to treat because their scarring tendency is very bad. So sometimes we even have to give them oral steroids to control this severe variant of acne. So this is just an acne conglobate lesion where you can see a lot of comedones. We can see papules, papular nodules. and definitely a few pustules over here. And this looks like a patient is developing into a very bad hypertrophic scar with a little bit of cystic element here. So these kind of scarring patients will be even more difficult to treat. So coming to the topic of today's discussion, acne scars. There are very many types of acne scars, of which the grading has been done very beautifully by the Goodman and Barron system of grading. So I will be discussing every individual type of scar and every individual type of technique and give you a tip on how to address a particular type of scar with a particular type of technique. That is what I do in my practice predominantly. So if you see, this is called a box scar. A box scar is a scar where the base of the the base of the scar is bigger. The edges are very well defined in comparison to the other scar types, and it is a wider scar in comparison to the depth. So if you see, the depth is a little shallow, broad base, as well as a sharp edge. When you come to a rolling scar, the skin has a very undulated manifestation. So not only are the lesions not very well defined, like most of the borders of the scars are ill-defined, they are all conglomerated next to each other. This gives the skin a very undulated appearance, and there is no particular definition of the atrophy or of the hypertrophy. And if you look at such a skin, the entire skin will be fibrosed, and such patients would have suffered from acne for years together. So it is very difficult to treat such patients who have very fibrous skin, a thick, indurated skin, because of all the amount of scarring over all these years. This is an ice pick scar, which is very, very frequently discussed amongst dermatologists because it's a little deeper scars. Here, the depth of the scar is much greater than the width of the scar. Even this has well-defined edges, as we can see, but the depth is much greater than the breadth. So definitely this requires a different modality of treatment, which we will be discussing soon. This is a hypertrophic scar. So it could also be developing into a keloid. We can never assess and say, but a hypertrophic scar is generally elevated, very thick in consistency, and a little bit harder or firm, and therefore a little bit difficult to treat. Keloidal scar, as all of us know, if you see, the rest of the patient's skin is relatively good. I'm not even sure if these keloids are poorly developed because of acne, but these keloidal scars are found in a very common area on the face, which is the jawline. And here the keloids tend to develop over the area of trauma. And at an area like this, where there is repeated movement, the keloids tend to develop even more. So keloidal scarring will also be discussed in the oncoming topic. So here are a few techniques. I will not be dealing with most of the oral medications because very few oral medications are used in the treatment of acne scars. So I will be discussing predominantly the procedures that are used for the treatment of acne scars. So chemical peels are something that address only the superficial layers of the skin. I would like to iterate upon the fact that anything that hits the dermis, any procedure that damages the dermis is going to have better results on the acne scar treatment than anything that is limited to the epidermis. Chemical peels, on the other hand, is something that is predominantly effective on the epidermis or maximum to the superficial layers of the dermis. So it is very useful in the post-acne hyperpigmentation. And when we use a deeper peel, like say a higher concentration of trichloroacetic acid or a higher concentration of salicylic acid, not only are we working upon the epidermal proliferation and trying to address the hyperpigmentation, but also there will be an element of penetration into the upper layers of the dermis. So this should be done in a very early phase of scarring. Now, microdermabrasion is something that most of us follow during practice. I have specifically mentioned it to let you know that it should not be used in acne scars. Not only is it avoided because predominantly the action of microdermabrasion is limited to the epidermis, you can see that this patient has a multiple open comedones, active acne with a few papules and pustules, and these could be actually infected. So doing a procedure like microdermabrasion is not going to address his marks, like in the areas where I'm pointing. Most of these marks will not be addressed, and we might even be disseminating the cutaneous infection as we use the microdermabrasion probes. So coming to the main topic of today, microneedling or any sort of needling is the one that is responsible for acne treatment and better results. The more there is dermal damage, the more there is good results. However, we should know what kind of damage should be used and what kind of therapy should be done for which type of acne to get the best results. The first and foremost type of microneedling that I would like to be discussing is called stamping. Stamping is done with microneedles where we can predetermine the depth of the needle, the microneedles that are penetrating into the skin at the level of the dermis, based on how deep the scar is and based on how soft or hard the skin is. Now, if you see this patient has relatively smooth skin, she was a patient who was on treatment for acne and she had a very, very mild, low depth of box scars. So we went ahead and decided to do the stamping technique, and we ensured that there is an element of pinpoint bleeding, not only to ensure that we've reached the dermal level, but when there is a pinpoint bleeding, it means there is sufficient of trauma to cause a little bit of micro hematomas and neoangiogenesis in the healing process. Thereby, the acne scar would have undergone neocollagenization and will be relatively smoother. So let me just show you how we go about doing it. It is imperative to stretch the skin as we do it. And this barely has any, yeah, you can see there is a pinpoint bleeding over there. So this barely has any errors because it is all predefined measurements and the tips are sterile and it's done after applying some topical anesthesia. So it's a very simple procedure that has to be done provided you are choosing micro needling for the box scars. So please ensure that you restrict your stamping technique to box scars because it may not be very effective for other types of scarring. So the other variant of microneedling is called the dermal roller. The dermal roller is something that may not be as precise as the stamping technique because there will be errors during handling the roller. The roller has microneedles that vary from 0.2 millimeters to even up to 3 millimeters. We usually use something less than 1 millimeter on the surface of the skin, and especially if the person has soft skin, we have to go down to 0.5 or 0.4 millimeters of the microneedle. However, thicker skin, more turbid skin, and something that has a lot more fibrosis might require a deeper needle. Here also, like I said, it is imperative to stretch the skin and roll the dermal roller on the acne scars. You can notice the pinpoint bleeding. This pinpoint bleeding is absolutely essential to create the subdermal hematomas, microhematomas, which are responsible for neocollagenization. Again, this should be done under topical anesthesia. Subcision is where it is just needling. It is not known as microneedling. And here, the needles of appropriate sizes are used. And in this, we address only ice-pick scars. Ice-pick scars because they are predominantly held deep down into the dermis because of fibrous strands. So we use the subsidizing needle, which can vary between even 20 to 17 gauge actually. It all depends on the texture of the skin. So the needle is inserted in such a manner that it reaches the upper layers of the dermis, so sometimes even the deeper layers of the dermis, and the needle is moved. The no-con needle is being showed over here, but you can always use the needle of your choice depending on the patient's lesion. So the bevel is facing upwards and the needle is being swiped to and fro under the skin. As you do this, you will actually be advancing and breaking the fibrous strands under the skin. And when this is being done, the fibrosis that is responsible for pulling down the skin and holding that puckered ice pick scar gives way. And when that gives way, the scar elevates. So this is something that has to be done exclusively for isolated ice pick scar lesions. Like I had said, once you release the fibrostrands, the scar elevates and the fibrostrands are completely severed. This is a picture of how subcision was done. However, this is not an ice pick scar. This probably is an area where there is a deeper scarring than the rest of the skin. But we chose this because it's a fairer skin. You can actually see the dermal hematoma that is being formed. This is a schematic view where the dermal hematoma is formed. This results in a lot of inflammatory mediators rushing to the skin and thereby resulting in a lot of growth factors which cause neoangiogenesis and neocollagenization to produce a smoother, supple dermis. Mesotherapy is nothing but the drug delivery into the dermis. This is direct drug delivery using needles. It could either be intradermal injections or one of the microneedling techniques. And the drugs that are used to be delivered can vary from indication to indication. Since today's topic is going to be acne scars, our indication is predominantly this anti-scar treatment, which could be Botox, or it could be hyaluronic acid, or it could also be some platelet-rich plasma injections, which are all injected into the dermis. However, most of these drugs only result in a rejuvenation effect. Mesotherapy and intradermal injection of any of these ingredients into the dermis is not going to be the monotherapy. It is always that should be augmenting or should be an auxiliary treatment to the microneedling or the needling technique. The microneedling and needling, like I said, should be chosen upon whether it's a box scar, whether you have many undulations and have to do a lot of dermal rolling repeatedly, or whether you need to do subcision for each individual ice pick scar. As you do this every session, you have to alternate this every session with an intradermal injection of the appropriate drug. So I have depicted hyaluronic acid, which is available as Volite. These are cross-linked hyaluronic acid, which are available in syringes. And this is responsible for collagen remodeling. You're going to be releasing any of these fibrous strands under the skin. You would like to augment the collagen remodeling by injecting hyaluronic acid. So we generally inject about 0.1 cc at a gap of about 1.5 centimeters. Again, this patient has undergone acne scar treatment. She had multiple box scars. She undergoes regular box scar stamping treatment, and we inject hyaluronic acid. She actually has, as you can see, she has a very good glow to her skin. However, the scars have resulted in a really dull appearance of the skin. So hyaluronic acid can be injected at the dermal level and at the appropriate spacing. So you can see that I'm injecting it, causing a little bit of a bleb on the dermis, and then going on to the next spot. Never inject directly into the marking. Inject about 0.1 millimeter away from it, because you don't want to push the ink into the skin. And this is the marking that is usually done around the area of scarring. This is a little bit of post-inflammatory hyperpigmentation, which will also benefit. So hyaluronic acid improves the texture as well as the hydration, because it's going to bring in a lot more fluid to that area. Water retention is happening around the hyaluronic acid. So the texture will improve, the hydration will improve. Coming to punch excision. Now, punch excision is usually chosen on patients like this who have very tethered skin. Their scarring goes right deep into the deep dermis, and not many needling or microneedling is going to address that deep areas of the skin. So we go ahead and do punch excision. We release that punch tissue, lift it up with a needle, and just excise it at the level of the subcutaneous area. Now, if you use a punch that is usually less than 0.6 millimeters, 0.4 millimeters, it's nothing to worry. You can just do it and excise excise it and let it heal by secondary tension. However, for such a patient who has very severe scarring and a bad scarring tendency and has already got very thick and puckered skin, it is imperative that you take a bite. You take a bite and close the skin because you don't want the excised lesion also to be healing with bad scar. So you take the bite according to the type of skin as well as according to the depth of the punch as well as the size of the punch. Coming to the dermal delivery of platelet-rich plasma, all of us know how to make platelet-rich plasma and inject it. We are all using it for non-surgical hair restoration techniques. And platelet-rich plasma basically, we know that basically functions by using all the derived growth factors which are responsible for collagen remodeling and neoangiogenesis. If you again see, platelet-rich plasma is never completely sufficient for treating acne scars. It is something that has to be used auxiliary to either the microneedling technique, the stamping or the dermal roller, or the absolute needling technique using the subcision. So platelet-rich plasma is ideally done in early scarring because it really improves the inflammatory mediators that are delivered to the the dermal area, and reduces the quality of fibrosis. It causes rejuvenation of the target skin. So it is very useful immediately after the patient he starts healing from acne scars to give a few PRP injections and then combine it with the microneedling technique of your choice. So, like I said, we all do it for our non-surgical hair restoration techniques and a lot of other procedures. So I usually take about 16 ml of blood from a patient, do a first spin for about 3 or 4 minutes, 2000 or 3000 RPM. You get the supernatant fluid. The supernatant fluid is usually platelet poor plasma, which is then undergoes a second spin, which is known as the hard spin. Here, the duration is for a longer time, as well as the rate of spinning can go up to 5000 RPM and almost 7 minutes of a spin. So again, we collect the deeper layers of that, which is actually the platelet-rich plasma. So done with all the auxiliary treatments. So let me revise that. First, we went through all the microneedling and needling procedures appropriate to whether it was undulating scars or box scars or ice pick scars. We did surgical procedure like excision or punch grafting of the scar. We did all the auxiliary treatments like mesotherapy, drug deliveries of hyaluronic acid or platelet-rich plasma. In fact, I haven't shown pictures of my mesobotox, but mesobotox is just an additional auxiliary treatment done for facial rejuvenation and very useful for pores. It is very, very useful for pore treatment. Coming to lasers or energy-based devices, the most common types of lasers that are available right now are fractional ablative and non-ablative fractional lasers. Now we all know, I'll just go through a gist of how these lasers are classified. So non-ablative lasers are very few but very effective. Ablative means there is destruction of the epidermis. So completely ablative laser is something that causes complete destruction of the epidermis. This brings about a lot of inflammation but has a huge downtime and can be very difficult to heal in patients with poor healing tendency. Fractional ablative is where areas of the skin is treated and areas of the skin is left behind, especially the epidermis. This is very useful because it really reduces the downtime for the patient after the procedure. The healing is much better because the healing happens from all the untreated areas of the skin. And something that is really in vogue right now is fractional non-ablative. Here, the epidermis is left intact, so which means none of the melanocytes and keratinocytes are really damaged, and the complete damage that happens is to the dermis. And if you notice, we're using carbon dioxide laser or erbium laser in these conditions because the target chromophore is in the dermis. The target chromophore is actually the water that is predominantly present only in the dermis and not in the epidermis. So a fractional non-ablative laser, especially a carbon dioxide or erbium YAG, is ideal for treatment of acne scars because the target is ideally the dermis sparing the epidermis and the keratinocytes and melanocytes. So these are the way the fractionated beams are delivered into the skin. The fractionated beams can be adjusted depending on the machine that you have. It can be adjusted according to the distance between every beam. Now, let me tell you, the more turgor there is in the skin, the more fibrosis. Not only do we have to give more sections, but the number of the space between every individual beam should be larger, because the healing capacity will be very poor. The more damage you do, the healing will be very, very poor. So the more space you give and the more repeated session you give, you're giving enough time and enough of surface area for the healing to happen. So this patient should be reminded that he will require more sessions. And if the patient has soft, supple skin, 1 or 2 sessions of the accurate area of scarred tissue can be done with a lot of microbeams that are being delivered into the skin. So the mechanism is very clearly depicted here. There's a microscopic laser puncture that goes down through the epidermis to the dermis. There are untreated zones that approximate and is responsible for the healing as it approximates, and we get fresh skin. So this does not happen in a fractionated laser. There's total destruction, so the healing time is much more, and there are chances of other side effects as well. So this is a histopathological depiction of how it happens. These are the microbeams causing destruction exclusively. A little bit of ablations happened in the epidermis as well. So after a period of 2 days, there's complete reepithelialization at the level of the epidermis, and the area of the dermis is developing a lot more collagen. Here, there's a lot more collagen being formed. Elastin is also evident. You can see the difference between the dermis over here and the dermis over here. So obviously the skin is going to be much more supple. The detail ridges are good, and there's complete epidermal regeneration. So all this fibrosis has come down to elastosis and collagenization. Hypertrophic scars and keloid scars, like I said, are the most difficult variant of scars that has to be addressed. Surgical treatment is very commonly required in these patients. However, they have to be repeatedly informed that it has a tendency to recur, especially if it is a keloidal scar. There are a lot of treatment options like imiquimod, and when the surgery is being done, apart from just the excision, we can combine it with a lot of other variations like mitomycin. But mitomycin is said to have poor healing, wound healing. Sometimes the surgeons also inject intralesional corticosteroids during the injection surgical procedure, so that the healing is better and the scar consistency is a little bit more atrophic. And laser is also a good option, but we never do laser ideally because of the tendency to have keloidal or hypertrophic scar already means that laser is not advised because their regular scarring will be bad. So preferably not to use laser. I've highlighted on 3 particular treatment methods that I do. Retinoids are generally given not only for the acne, but even after acne, I prefer to give it for a few months because it adds the retinoid glow because of the increased vascularity. And the increased vascularity facilitates neocollagenization, and the texture of the skin, the scarring tendency, the fibrosis is much lesser. So hypertrophic scars do not actually get hypertrophic. We can actually control the hypertrophy of these scars. Cryotherapy is regularly done, and intralesional steroids is also regularly done. However, when I do intralesional steroids, I ensure that we use only 10 mg per ml. It is diluted in more than 2 or 3 ml, and very small quantities are being injected, because if a lot more quantity is going to be injected, we're going to have other side effects like atrophic scarring or follicular dermatitis changes on the skin, especially because it is on the face. It has to be administered very carefully. And when surgical procedures are associated with intralesional injections, again, the dilution has to be very, very scanty. I'd like to thank FODS for giving me this opportunity to discuss the little bit I know about acne scars. I really hope that just these 4 or 5 tips that I gave will help you in choosing the right procedure for the right type of acne scar and to go ahead with appropriate auxiliary treatments. Thank you very much, and I would give a special gratitude note to Dr. Nitya and Bhuvana for giving me this opportunity. Thank you.
Yeah, thank you so much. Thank you so much for the intriguing and detailed session on acne. The tips and techniques that you have discussed are very useful and informative, ma'am. I would like to extend my thanks to all the registrants for joining with us today and hope that you had a useful time. Ma'am, can we just start the question and answer session? Like, I have
Yes, please,
two
please.
questions from our registrants. So,
Yeah, you can moderate the questions.
yeah,
I'll be more than happy with a
yeah, yeah.
discussion that all of us have a lot of doubts, including me. So,
Yeah, okay. So, which needle would you prefer for subcision? By Rajiv Sule.
actually, I go ahead with the smaller needles, like 23 gauge predominantly, because if you're going to be using a longer 1-inch needle, whatever size of the whatever size of the gauge it is, if it is going to be a 1-inch needle, the arc is going to be very, very dynamic. So you'll be releasing more tissue, but you can also damage more tissue and you will not have adequate control. So I prefer to use the 1/2-inch length needle, and the gauge can vary anywhere between 23 to 20, so that you can have good control and enough release of the fibrosis. However, it also depends on the texture of the skin, and you can go ahead with a longer length only if the skin is extremely turgid and extremely fibrous, or else the smaller needle at around 23 to 20 is adequate.
Thank you so much, ma'am. Thank you, Rajiv, for the question. Next question, like, how do you treat acne PH of long time? PIH of long time from Ankita.
Acne pH of long time, first I'll go ahead with topical applications of azelaic acid or kojic acid. I will combine it with the topical peel like I had mentioned, and this time I will not limit myself to a glycolic or a mandelic acid peel. I'll go with something a little bit more potent like trichloroacetic acid or a salicylic acid peel. But however, every night the patient should continue applying azelaic acid and glycolic acid because of its specific action on the melanocytes. So it can be a combined treatment, especially if the patient has long-term post-inflammatory hyperpigmentation. Another thing that I would like to mention is Q-switched Nd:YAG laser or a pico laser is a very good option for long-term post-inflammatory hyperpigmentation. And it is very essential as dermatologists to find out the reason for the post-inflammatory hyperpigmentation, because most of the patients who have post-inflammatory hyperpigmentation also have coexisting hormonal disorders like insulin resistance or even polycystic ovary disease in female patients. So evaluate the reason of the PIH, try to go conservative with topicals, and if it still doesn't resolve, add the appropriate laser, which could be Q-switched Nd:YAG or a pico laser.
Thank you, ma'am. Thank you, Ankita. And how significant is diet in acne formation by Ashwajit Puri?
Very significant. In fact, that's why it was my third or fourth slide, because diet is something that is very responsible for increased sebum production. It causes hyperandrogenism. So when you have a poor diet with a lot of processed products, there is a lot more of hyperandrogenism. And when there is hyperandrogenism, there is increased sebum secretion and plugging of the pilosebaceous unit. So that is one way in which the diet influences the skin. The second is, if your diet is going to be poor and you develop insulin resistance, then definitely your cutaneous immunity will be poor, and there are more chances of your commensals on the skin to start proliferating more, just simply because your overall immunity is poor. So definitely high glycemic index food will facilitate more oil production, blocked pores, as well as secondary infection of the pores.
Thank you, ma'am. Thank you, Ashwajit. Then subcision is best for which scar?
Ice pick scars.
Okay. Okay. Thank you, Gaurav. And one more question from Gaurav is types of punch methods in acne scars.
So usually I just do the single punch, and I punch and excise the lesion. So other than that, we do not do any other sort of punch method as such. You just keep the punch, rotate it into the skin, pick it up with a needle, and just excise it.
Thank you, ma'am. Thank you, Gaurav. From Anshu, your preferred peels in acne patients and in acne scars. How to manage erythema in fair colored skin?
Yeah. So first is acne, active treatment, chemical peel for acne or active acne is salicylic acid or trichloroacetic acid. Salicylic acid is something that I choose for darker skin people because the post-inflammatory hyperpigmentation is lesser and it's very, very specific for the sebum. Trichloroacetic acid is something that penetrates a little deeper. It has a little bit of an effect on the deeper layers of the epidermis, the melanocytes, as well as the upper layers of the dermis. So if the patient is fair and has very bad acne, I choose something like trichloroacetic acid. The patient has a generally deeper color like skin tone 4, 5 or 6, then I choose glycolic acid along with salicylic acid because salicylic acid is something that's essential to control the sebum production.
Thank you, ma'am. Thank you, Dr. Anshu. And we have got a few more questions. From Dr. Anila Farooq, like how to minimize pores?
Okay, so this is a lot of people come to me asking this question. So the reason for pores is predominantly dehydration. So what happens is there is a loss of turgor in the epidermis and loss of turgor in the dermis that causes a non-inflammatory pitting of the individual acne, the pilosebaceous unit. Sometimes the acne itself resolves with small pores because of a very microfibrotic strand over there. So it is essential to do dermal collagen remodeling. So one of the most important technique is microneedling RF. Like I had mentioned, it is a non-ablative treatment of the deeper layers of the dermis. So the outer of the dermis is needling RF go inside the layer of the dermis and cause the radio frequency effect that is responsible for neocollagenization. I also personally feel a little bit of bolite treatment, that is hyaluronic acid injection, is very useful, very little and at adequate separation because it brings about a lot of hydration. The texture of the skin changes and thereby the pores tend to smoothen out. It also improves the elasticity of the skin, so the turgid skin, because of the lack of water and more fibrosis, is released. So I would either do microneedling RF or combine the microneedling RF to bolite injection or hyaluronic acid injections.
Thank you, ma'am. Thank you, Dr. Anila. Then, ma'am, do you add any topicals for scars before procedure, like Pixelac?
No. I see the thing is Hexelac or silicone is very useful for hypertrophic scars, keloid scars, burn scars, but it can never be monotherapy. And usually when we apply Hexelac, we are silicone gel, we are advocated to use the silicone sheet to stick onto the skin. Now, it's not really practical for a patient to stick on silicone sheets onto the face and go to bed. So every night. So I don't give them the silicone sheet to stick on the face or anything of that sort. However, in these areas, if there is a lot of hypertrophy, I do combine topical silicone or silicone sheets to the regular modality of treatment.
Thank you, ma'am. Then one more question from Rajiv Sule. Please guide for treatment of closed comedones.
Closed comedones, if there is too much of seborrhea, I will give the patient, and all the criteria are met, like for retinoids, like this, we rule out the liver function abnormalities, we check for their dyslipidemia, patient is counseled against contraception. Then if there is a lot of seborrhea with open comedones, I give retinoic acid, low dose retinoic acid orally. If the patient doesn't fall under these categories, then salicylic acid peels are ideal. You give them a good 2% salicylic acid face wash And depending on the skin type, you can vary between 30 to 70% salicylic acid and the amount of post-hormones they have. I think this should be fine. The conservative treatment, the face wash, as well as the procedure.
Thank you, ma'am. Thank you, Raji. Then one more question from Nisha. How can we treat scar on active acne?
Yeah, so scars on active acne, I would definitely give retinoids, oral retinoids, because like I had mentioned earlier, retinoic acid works on the acne as well as on the result of the acne scars. And if the patient has just atrophic scars, we can wait for the active acne to resolve with retinoic acid. But if the patient is going to suffer, then simultaneously we have to start giving them silicone before doing the. Permanently, we control the type of scarring, we treat the active acne with retinoic acid, and then go about treating the acne scars individually, because most of these procedures has the tendency to disseminate any type of cutaneous infection. So I personally would avoid treating the scars when the acne is active.
Thank you, ma'am. Thank you, Nisha, ma'am. Then Devi, your take on TCA across for ice pick scars.
It's good, but it's definitely not a monotherapy. It's definitely very useful for fair-skinned patients. It is very useful, but it cannot be a monotherapy. You do require some element of subcision to release that extensive fibrosis that's responsible for the ice pick scar. The fibrosis has to be released. Definitely, there will be collagen remodeling when you are going to be doing a TCA cross. So you can combine it.
Thank you, ma'am. Thank you, Dr. Devi. Then one more question from Gaurav. Which scars, punch methods are done in which scars?
Punch methods are preferably done in ice pick scars. I also really recommend punch methods for chickenpox scars, because it's something that is associated with a lot of depression, a lot of dermal fibrosis, a lot of post-inflammatory hyperpigmentation, and like I already mentioned, very well-defined sites and very deep scar. So punch method is very, very useful for ice pick scars. Never try punch method for undulated scars, rolling scars, or box scars, because you will never be able to remove the scar in total. They will all be a little broader than your punch. We are likely to make that mistake, all of us. So better to use it on an ice pick scar so that you can remove the ice pick scar in total.
Thanks, Gaurav. Then please guide for treatment. Okay, that is done. How is punch elevation done? From Tejas Vishwanath.
The punch scar, sometimes you just leave behind that punched tissue and do a small dressing and let it heal, because sometimes the surrounding collagen just forms a neocollagenization and holds the skin together, so that the punched tissue and the epidermis that was initially depressed will be held together and it will get elevated. So that is one way in which it will get elevated spontaneously. So you can leave behind the punched tissue, especially in soft, supple skin. It can also be done in skin that is dispersed with other type of scarrings. But when you're doing a punch, do not do this for a chickenpox scar, because the ice pick scar or a box scar, because of chickenpox, is relatively deep. It is altered in pigmentation as well. So it is always better to remove that scar in total. For patients with very good skin with an ice pick scar, do the punch and leave it behind and let it heal.
Thank you, ma'am. Thank you, Tejas. Then again, one more question from Devi. Can we do procedures like subcision, MNRF in patients with active acne?
No, I wouldn't do it, because subcision is also going to be inserting a needle through the skin, and the patient might be harboring Propionobacterium acne on the skin at that time. So when you're inserting, no matter how sterile you are during the healing phase or during the patient's daily routine, they may not take care and you can get a secondary infection. Very, very problematic if the patient does get a secondary infection. Number one. And number two, MNRF also you're going to be inserting the microneedles when you're going to be doing the procedure. So it's better to avoid that. When we do a chemical peel, it has an antibacterial effect. So that is one reason why it can be used in a patient with active acne. But most of these microneedling or needling techniques are advised to be avoided in active acne.
Thank you, ma'am. Thank you, Devi. Irina, what is your experience with cross TCA results for ice pick scars?
I do have a little bit of experience, but like I said, I'm never satisfied with just TCA cross. TCA cross has a result, but it's never a very satisfying result. You know, you have to do an element of subcision. You have to do an element of releasing that fibrosis, or else doing the TCA is effective, but it's never completely satisfying. And the patient also they are satisfied, but to see the overall texture of the skin, it's better to combine it with a session of subcision in ice pick scars, especially.
Thank you, ma'am. Thank you, Irina. Then one more question from Devi. Ma'am, do you do procedures when patient is on oral retinoids?
It depends on the procedure. So very rarely do I do the procedure when the patient is on oral retinoids. Unless the skin is absolutely clear, healing very well, patient has been on oral retinoids for 3 to 4 months and the patient is used to it, there are no chances of the patient to get post-inflammatory hyperpigmentation, because say a procedure like subcision or a procedure like stamping is not going to cause any side effects. However, if you're going to be doing derma roller, you're going to be abrading the skin further, and the skin that is already peeling because of the oral retinoids, better not to do any of the lasers, better not to do any sort of a chemical peel, and better not to do any sort of eh, an abrasive procedure. Subcision is probably a consideration, but most of the times I try to go as conservative as possible when the patient is on oral retinoids.
Thank you, ma'am. Thank you, Devi. Then what is the role of PRP in acne scars from Pallavi?
So PRP is never a monotherapy for acne scars. PRP is something that can be done as an auxiliary treatment. So the patient has to be classified as to whether they have undulated scar, box scars. The individual scars has to be classified, treated accordingly by microneedling or stamping, as we just discussed in detail. And apart from that, in between sessions, we can give the patient PRP because it's going to cause neocollagenization, it's going to cause new angiogenesis, and thereby the texture of the dermis is going to improve. There's going to be hydration, there's going to be more collagen, and therefore any sort of procedure is going to be augmented by the PRP procedure, but it's never a monotherapy for acne scars.
Thank you, ma'am. Thank you, Pallavi. Then another question from Rajiv. Please elaborate TCA for box scar, like what percentage, plain TCA or TCA cross?
Box scars, TCA can be done, plain TCA, and plain TCA just but again, box scars, I prefer microneedling because TCA definitely has a result, but never a satisfying result. Like I said, most of the scars are because of dermal fibrosis. So any procedure you do, you have to go into the deep layers of the dermis and release the fibrosis. TCA is very good as long as it causes dermal remodeling, but only in the superficial layers of the dermis. So going deeper down into the dermis and releasing that fibrosis is essential. So TCA can be done for box scars, but stamping or microneedling is absolutely essential to be done along with it.
Thank you, ma'am. Then what are the treatments of choice of all types of atrophic scars individually from Gaurav?
Yeah, so this will actually be summarizing my talk, all types of scars and how to treat it. So first, box scars, my preference is microneedling or stamping. There's a lot of undulation and the patient has a lot of rolling scars, undulated scars, nothing is really well defined. We can go ahead and do lasers, CO2 or erbium lag fractionated lasers. We can do derma rolling if the patient is patient is obviously not affordable for laser, or if the patient has skin and laser penetration alone is not enough. Laser has to be combined with derma roller. So if the patient has ice-pick scars, we can do subcision or we can do the punch technique. So these are the three ways. Box scars is microneedling and stamping. Undulated scars are lasers as well as um, microneedling, and of course, ice-pick scars are punch, excision, or subcision. Along all these techniques, you can co-treat it with PRP injections or hyaluronic injections, simply because you want to augment the collagen remodeling.
Thank you, ma'am. Thank you, Gaurav. Then one more question from Dr. Sanjay Kumar Upadhyay. Treatment of nodulocystic acne.
Treatment of nodular cystic acne, say if the cysts are about to burst or if there is active pus secretion, please do a pus culture sensitivity, because in today's era there's so much of bacterial resistance and there is antibiotic resistance amongst the bacteria. And if the pus is all engaged within cysts, please go ahead and use high dose retinoic acids, especially keeping in mind the liver function test, the dyslipidemia, and counseling the patient against conception. You can go ahead and give retinoic acid. Also, give a course of antibiotics before starting the retinoic acid. It's better to control the infection with the antibiotic of choice, preferably along with culture sensitivity, and then follow it up with a high dose retinoic acid. Remember that retinoic acid itself has an element of antibacterial effect. So nodular cystic acne, these are all the systemic treatment options. Unless it forms something like Acne Conglobate and it requires even intralesional steroids or oral steroids to get rid of that active, severe inflammation. So the regular nodular cystic acne, just those three options are fine.
Thank you, ma'am. Thank you, Dr. Sanjay. And from Ankita, what percentage of lactic acid can be used on face? Does that help for acne scars?
Lactic acid is a very, very superficial acid, and it is very specific for, it actually is a very superficial acid. So it really doesn't penetrate deep. So it's available between 10 to 30% lactic acid. It's barely used as a monotherapy. It's never barely used. In fact, many people use lactic acid peels as the party peels that are available just for that superficial exfoliation and superficial desquamation that gets rid of that tan and adds a glow. It is better not to use lactic acid for acne scars because the results will not be that good. It will not penetrate into the deeper layers of the dermis. Lactic acid has very good results only for pigmentation or that temporary tan, and has a temporary benefit in the form of party peels or in combination with other peels for a temporary effect.
Thank you, ma'am. Thank you, Ankita. And then from Dr. Anshu, role of topical hyaluronic acid.
Topical hyaluronic acid has a very, very borderline thing, because hyaluronic acid is supposed to be hygroscopic. So it has to penetrate with the help of a lot of water. So if the patient is going to be having dry skin and you want to penetrate the hyaluronic acid into the dermis, the chances of penetration is very, very less, because we always have a very strong skin barrier in the form of an epidermis. So for the hyaluronic acid, which are larger molecules, to penetrate into the dermis is very difficult. So penetrate through the epidermis to the dermis is quite difficult for such large molecules of hyaluronic acid. So it is always better to inject the hyaluronic acid into the dermis so that it settles well. It forms the hygroscopic effect and thereby improves the turgor of the dermis.
Thank you, ma'am. Then from again Dr. Anshu, like how to manage erythema in fair colored skin?
Yes, someone asked me.
Yeah.
So first and foremost, sunscreen is very, very important for erythema in fair skin. And if you're talking about something like rosacea, you can also give a little bit of metronidazole, and there is erythigo gel that's available now. So erythigo gel can be given in the case of something like rosacea. But if the patient has post-acne erythema, just not as a result of rosacea, but as spots of erythema, then we definitely have to give them erythrico gel. It's the only option. There's right now there's barely anything else that's available, and always combine it with a sunscreen because you don't want to incite more inflammation and more erythema.
Thank you, ma'am. Thank you, Dr. Anshu. And from Ankita, does subcision itself doesn't cause scarring? Sorry.
No, because see, the size of the needle is nowhere close to a size that can cause scarring by secondary intention. The scarring that is caused by inserting a needle is always by primary intention because it does not the breadth of the needle does not cross 0.3 millimeters. Anything less than 0.3 millimeters just heals with primary intention. So you don't have to worry about it. It's just like giving an injection on your deltoid or gluteal region. So we don't have to worry about it. The purpose of the needle is to subside the fibrosis. The injection itself of the needle, the piercing of the needle will not cause scarring.
Thank you, ma'am. Thank you, Ankita. Then from Arun, what's your experience with dermabrasion with burns and deep acne scars?
In burns, dermabrasion is very, very risky because in burns, the thermal damage that happens to the collagen is so much in the dermis that there is severe fibrin formation. There's a lot of fibrin formation and a lot of hypertrophic collagen. So if you're going to be abrading that further, you're going to be inciting a little bit more of collagenization. So in the type of burn scars that are there, it either causes hypertrophy or contractures. It's never like an acne scar, which is just atrophy of the skin. In burn scar, the thermal damage is so much that it penetrates through and through. Sometimes it goes even up to the lower layers of the subcutis, completely causing contracture of the skin. So a regular dermabrasion that reaches up to the layer of the dermis is just going to incite more and more inflammation. So if there is contracture or severe hypertrophy that's found in burn scars, it's better to inject a little bit of steroids to reduce that inflammation, to reduce that active fibrosis and contractures or that active hypertrophy and the keloids that are being formed from that severe thermal damage. And if necessary, they can also undergo excision because they don't have a keloidal tendency. So they can get it excised and reconstructed by the plastic surgeon, or we can inject it with steroids to loosen up and reduce its inflammatory effect and smoothen the type of scarring.
Thank you, ma'am. Thank you, Arun. Then from Pallavi again, what is the line of treatment in hormonal acne?
Hormonal acne, we definitely have to see the hormonal issues. The patient is suffering from polycystic ovary. I generally try to give them the OCPs appropriately. Sometimes these patients have hyperandrogenism and hyperinsulinemia also. When there's hyperinsulinemia because of insulin resistance, I combine it with metformin. So it depends on the hormone that is involved. It could either be OCPs for polycystic ovaries, or it could be metformin for insulin resistance.
Thank you so much, ma'am. Thank you, Pallavi. I hope all the questions are done so far. So thank you so much, ma'am, for patiently answering all the questions. And once again, thank you all the registrants for actively participating. Yeah. So, any more questions?
Coming to hormonal acne, see, this polycystic ovary syndrome is because of an imbalance between the estrogen and the androgen hormones in the system. So we give the OCPs in regulation of their cycles because invariably a patient with polycystic ovaries has irregular periods. They have an irregular cycle. So as we give the OCPs, the irregularization gets regularized, and in that process, the imbalance between the hyperandrogenism and the estrogen balance is also regularized, and thereby the tendency to form acne comes down. So OCP should be given for a minimum period of 3 to 6 months in these patients. They should also be counseled about it, and also about lifestyle changes, both. In the case of hyperinsulinemia, they should be counseled about their lifestyle changes and their diet. And in the case of PCOS, also they should be counseled about their diet and exercise habits.
Thank you so much, ma'am. So thank you for answering questions patiently. So on behalf of FODS, I thank you for joining with us and sharing us your valuable information, ma'am. And thank you all the registrants for listening to the talk, and hope everybody had a useful time.
Thank you.
Yeah, thank you. Thank you so much.